أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. So previously actually this is session number 2 which we want to start about as the radiology is concerned. This is session number 2. In the first session I have spoken about the requirements of the plain X-ray chest. Requirements should be fulfilled. The patient should be S plus S plus S. It should be PA view, and the patient position will be S for straight, S for still, S for straight, S for still, and S for standing. S plus S plus S. At least these requirements should be fulfilled for the X-ray chest is concerned. Now afterwards I said that how to read this X-ray. There is a protocol, reading protocol has been shared with you previously, like this one, which is more beneficial to the students, that is features should be normal X-ray. First of all, you have to label the X-ray normal. You have to read normal X-ray. Then abnormality will be added in it. So differentiate between the normal X-ray chest and the abnormal X-ray chest. So one should have enough knowledge to label the X-ray as normal chest X-ray. The protocol is that first of all the bony skeleton will be seen, then go for the soft tissue, then trachea, lung fields, lomes of the diaphragm, lower middle mediastinum, upper middle mediastinum, and hilum left and hilum right should be studied separately. Then conclusion, what are the positive findings of X-ray and what is the differential diagnosis, and then we advise whether you will treat yourself or you want other investigations or you want to refer. So this is how we report this X-ray. This is a good way to do it. Otherwise, the mnemonic is DRSABCDE, fastlane.com, basic X-ray interpretation. It is from the internet. D for details, R for right images, that is the rotation and inspiration and picture quality, exposure, etc. As for soft tissues and bones, A for airways and mediastinum, B for breathing, C for circulation, D for diaphragm, and E for extras like CBB lines, etc. Now this mnemonic is okay, fine, no problem. But this is the good way which I have told you to do it. So now we start the session of the protocol, how to read it. First of all, the bony skeleton. What you want to see in the bony skeleton is the rib cage should be examined. Now the rib counting should be done like this. This is the first rib, this is the second rib, this is the third rib, this is the fourth rib, fifth, sixth, seventh. Between the first rib and the second rib, first intercostal space, second intercostal, third intercostal, fourth intercostal, fifth intercostal. Now it is the costal cartilages which is actually making the joint. It's called the costochondral joint. And this costochondral joint will make a joint with the sternum, mesosternum, except in the first rib and the second rib, which is attached with the manubrium sterni. Basically, otherwise all are attached to the sternum. You know there are true ribs and the false ribs and the floating ribs as well. So bony skeleton should be checked. This is the rib cage. We have to see anything in the bony skeleton is concerned, including the ribs. These are the ribs. This is the clavicle. And this is the spine. Here is slightly scoliosis is seen in this case. Starting with the first one, that is clavicle, making the joint, the shoulder joint is a part of it, and it is making the joint with the what is known as the scapula, and this is the joint here, which is made by head, the clavicular lateral end with this. So this joint should be checked out. Okay, fine. But the thing is this clavicle here, this is the medial end, this is the lateral end. We divide this clavicle into 3 imaginary lines. Now, this is here is the part of this third line, second line. So it is the lateral, this is the middle part, and this is the medial part. Where the clavicle changes the direction, this is the mostly we see in the fracture cases. This is the part. But the direction is changing here. So the strain of the force, when it's transmitted through it, it will definitely, it should go like this. But it should be actually angulation occur, therefore it breaks out. The two-way direction of the force applied to here, it transmitted to the clavicle. First of all, the upper border and the lower border should be checked out. It should be now symmetrical border. It should be symmetrical. Secondly, see in the area here, radiodensity is visible. In the clavicle, you see the radiodensity. It is dark because of the lung. Alveolar spaces have got air, is masking the density of the bone. If it becomes the lateral 1/3 is radiodensity equivalent to it, this one and this will be the same, then it means that osteoporosis has occurred in this bone. This is the commonest bone in which the osteoporosis also can be checked out. So clavicle itself is concerning, is a very important point to be examined for. Clavicle, the joint along with it, scapula here, it is the lateral border, here is the medial border of the scapula. Scapula medial border, it should not be inside the thorax more than 2.5 centimeter. If it is more than that, the axis should be discarded. Because if there is density here, radiopacity, pathological, it will be masked or isodense. So its opacity will be definitely cannot be defined, and the X-ray will be regarded as normal. So it should not be under this, more than 2.5 centimeters. It should not be under this. Now this is the rib cage, the first intercostal space, the second one, the third one. You can see if it enlarges like this. The first, the second, the third, the fourth, the fifth, and sixth. Further count the ribs properly, intercostal spaces, the upper border, the lower border of any rib, catch for it. This is the posterior attachment. It should be discarded as far as the counting is concerned, because the physician will count in this fashion: first, second, third, fourth. So upper border and lower border should be very symmetrical. Very, very regular borders they are. Inside any of this, there is nothing is seen here. This is a normal thing in any X-ray. Look, the scapula here. Here is it is the lateral border, which is outside. correct X-ray position. It is not under this. So, this is about the rib cage is concerned. Now, if you see the chest wall deformity are seen in these cases, as chest wall deformities occur because of the spine. This is cervical, it is a thoracic spine. Here, what see is the lateral outgoing spine. It is scoliosis. It is thoracic spine scoliosis. If there is a scoliosis, possibility of the kyphosis occurs. If the patient is kyphoscoliotic, there are many changes in the clinical examination as well as investigations are concerned. For example, electrocardiogram, there will be changes. For this person, it's normal, of course, because it's kyphoscoliotic. It should be described that there is a chest wall deformity. And these are another deformity which is shown here on this side. There is scoliosis. The lateral view should be done for the kyphosis. In many cases, it is associated with the kyphosis. Fractures are seen and very, very difficult for anybody to detect the rib fractures. It is not easy one. How you will detect them? Upper border, lower border. Make it very, very clearly upper, lower, upper, smooth here, lower, smooth, yes. Then down there, upper border, then lower border, okay, and then upper border. Here it is, there is a gap, and then it is continuous. Again there is a gap here, there is continuous. The other ribs, the upper and lower border are symmetrical. On this side, upper border, lower border, upper border, lower border, upper border, lower border, upper border, lower border. Continuation, symmetrical borders. There is a chances of fracture here and here. It's very difficult. Usually, if it is only visible, many people, when there is displacement of the two parts of the ribs. One is displaced here, one is displaced there. It is a clear-cut displaced fracture. It is not displaced fracture here. It is just hairline fractures. More commonly seen after matches, after games. Somebody is actually beating the other person, boxing for example, etc. Or accidents, cyclists do have these type of fractures. Very painful condition. Now here you find in the rib, you see on the rib, costochondral junction, you see there is opacity, round shaped opacity. This is ricketry ROSARY. You see in case of the rickets in the young population, rickets, children and young population. Rickets will be seen and osteomalacia in the more older population. Rickets will be only seen in the young and the children. Rosettes formation here. Now another problem is the looser zones. The looser zones is a zones you see. This is the direction of the ERC. There is, you find there is line, see the lines here. Serrated serration here. It is not regular like this. Serration. Now it is seen only in one condition in the world. And it is the syncytial, and that is in case of the osteomalacia. Looser zones are also seen in the scapulae. Looser zones are also seen in the iliac crest in the pelvic bones. The looser zones are the synchron, hard data, radiological hard data for the osteomalacia. Now, notching of the ribs, rib notching, that's something here you see the posterior attachment, you see the ribs, there is margins like this, serrations. It's not regular, here is like this, combing effect. Now, it is seen in cases of the many conditions, and it is called, rib notching is called dock sign. Dock sign is seen where is limb notching was present, and there is differential diagnosis of rib notching. One, the cardiological finding, as you see, in case of coarctation of aorta, you see in the cases of venous malformation of the intercostal veins, because the intercostal arteries is running in this lower border, arteries, veins, lymphatics and nerves. As far as this is concerned, because of the coarctation of aorta, the anastomosis is widespread, and that is why the arterial site is dilated and tortuous. It is serration. Venous malformations can cause this, no doubt about it. And in case of the lymphangitis, carcinomatosa, or lymphatic blockage, you find again these serrations or rib notchings. Neurofibromatosis, nerves are involved. You also see these rib notchings. So dock signs are seen in these 4 or 5 conditions. If you remember, that's okay, fine. If you don't remember, only one, and that is important thing is about the coarctation of aorta. Now, secondary in the ribs will be seen upper border, lower border. Inside there is osteolytic regions. You find osteolytic regions in the on the ribs anteriorly as well as the posterior attachment here, like this. Secondaries in the ribs, also altering that radio texture of the ribs. What is the cervical rib? Cervical rib is complete. If it is complete cervical rib, accessory rib, it is short one arising from the rib is arising from the T1 thoracic. Cervical rib actually is the accessory ribs. This one is the short one. It comes on the lateral side. It will not come like the first rib. First rib will come like this. The first rib is not first rib. It's accessory rib because it's a short one. It's end here. The first rib is here, this one. So this is accessory rib, bilateral. It is complete cervical rib. It will cause the pain and the neck pain radiating to the shoulder and the upper limbs. Outlet syndromes, what is called as this is one of the outlet syndromes of the axilla is concerned. The thoracic outlet syndrome, one of the causes is because of the compression of the nerves. This thoracic outlet syndrome, it is one of the cause of cervical complete ribs, bilateral. It may be incomplete, half of it also causes the pain. So surgery only indicated when there is all features of the thoracic outlet syndromes are present. Look the scapula about it. It's medial border, lateral border, upper border, and acetabulum is seen here. So this is the joint composed of this is a shoulder joint. Any fracture you see here very, very clearly, it may be visible. It is not common. Although the commonest actually is the clavicle fracture. And this is a linear fracture you see on the scapula. Down there There is another condition that is called winged scapula, just like this. This is the whole here, scapula lying here instead of here. And it is the nerve which is gone, supplying the most of the muscles which are attached with the scapula, long thoracic nerve. Damage to the long thoracic nerve will cause this winged scapula. It may be unilateral, chances are there. This is a big one. On the one side, the hump is there. Something about the cervical vertebrae, you see the attachments of this. This is the first rib. It is complete rib, here is ending. Because the costal cartilage is not visible, it is attached with the mesosternum, the manubrium sterni, and causing, and it will form the joint there. The second will attach also on the part of it, second rib, attach also with the lower part of it. So this is the first rib is arising. The back picture, if you go from the back, you find the cervical vertebra arising from here, C7 and above C6, etc. It is a thoracic spine down there, although it is a PA view. All the things are not visible here. Now, if it is cervical vertebra, for example, then you see what you see the body. What you see here is the intercostal spaces and transfer processes. The transfer processes will be definitely continuous. It is a joint made by the ribs. The transfer process of the thoracic vertebra, not cervical. For example, take it as a cervical vertebra. You see the body, the intercostal spaces should be equal. It should be in one line. In one line it is, should be. Soft tissue around the chest wall should be checked. These are soft tissues around it, diaphragm. Now look here, these are the soft tissues in the neck also. Now here in the middle superior mediastinum you find an opacity here, soft tissue opacity. Now here, and this is a sign of called sailing sign. In the old ages, when you see the sign, when the ship or small boats made of the clothes of the cotton, high cotton, they raise this for the direction of the movement of the ship there. So it's a sailing sign in the THYMOMAs. Again, it is a big subject of THYMOMA. Upper part of the mediastinum or superior mediastinum is involving here. This is aortic nickel. Foreign body in the chest wall. See here. This is the pin inside the chest wall. Somebody has penetrated it. This is the pin. This is the condition in the psychiatric patient. He is a psychiatric patient. But you see here, there is a soft tissue also, there is a line of aerograms. Here it is moving in direction, see the direction of it. It is moving now in the neck. If it is dangerous. It's called surgical emphysema in the chest wall and moving to the neck. You have to give a cut at once to relieve it, otherwise the patient will die. So this is the trachea. We have to see the tracheal position. This is the aerograms which are called tracheal aerograms. This one, this one, this one, this one. Now trachea ends at the sternal angle. Trachea ends, or fourth thoracic spine. There is no trachea. It will divide into two, the right pencil bunkers and left pencil bunker. It should be straight. It should be straight or 10 degrees towards the right is the normal. Make two lines. One is transverse, one is vertical. If it is 90 degrees on both sides, is normal, or 10 degrees towards the right side, it is normal. Otherwise, it is called displaced trachea. and place trachea this on the right side. It may be pulled, it may be pushed. When it is pushed due to the tumor, it is pushed by the tumor, by the pneumothorax, by the excessive pleural effusion. Pulling effects occur in case of the collapse on the same side. Collapse, number one, very important condition. And second one is the fibrosis, the cicatrization or contraction of the fibrous tissue. Now this is again a soft tissue basically here in this upper part, superior mediastinum. It should be diagnosed as a thymoma, but it is an old person. So retrosternal goiter can appear in this, and any tumor arising here, other than this is a case of retrosternal goiter. This is one. Soft tissue status. This is the end of session 2. I hope that you will try to remember this session. I am very thankful to you to attend this session. You repeat it 2 or 3 times, then you can understand very easily. Inshallah, we will meet again. Assalamu alaikum wa rahmatullahi wa barakatuh. Wa ma alayna illa al-balagh.